Welcome to the PICon 2021. We thank our esteemed speakers and faculty and the delegates who have spared their extremely valuable time to be here with us. And we look forward to a very interesting session. I asked Dr. Navneel to start making the announcements for the chairpersons, the moderators, and expert panelists. Over to you, Navneel.
Thank you, sir. Good afternoon. Wishing everyone a very warm welcome to the Eastern India Interventional Cardiology Conclave 2021. Our first session deals with chronic total occlusions. May I humbly invite on screen the chairpersons of the first session, Dr. Aftab Khan, Dr. Kashinath Ghosh Hazra, and Dr. Shapon Paul. Moderating this session will be Dr. Arun Kollan Sundaram. And our expert panelists will be Dr. Ashish Jha, Dr. Aditya Verma, Dr. Polash Mondol, and Dr. Saurabh Ghosh. May I request the respected chairpersons and moderator to start the proceedings.
Thank you for having invited me for this meeting. It's truly a privilege. Good to see friends here. Hi, guys. And I know we would like to stick to time. So without further ado, I would like to invite the first speaker to deliver the talk, please. I'm assuming the introductions have been made already, correct?
So I think we have to make a short introduction.
So, I mean, it's...
Yeah, Dr. P.K. Goel. Professor Goel is well known to us.
Yeah, I mean, Dr. Goel needs no introduction. I mean, he's one of the IJCTO founder members and one of the CTO experts in the country. So he's a full professor at STPCI and one of the foremost names in CTO PCI in the country. So it's truly an honor and a privilege to invite him to this meet. Dr. Goel, floor is all yours.
Well, sir, are you there, sir?
Dr. Goel, you need to unmute. We can't see you or hear you. Hey, can someone from the technical team help?
Yeah, Goel sir, I have sent a request to unmute yourself. Please click on that. Goel sir, please unmute yourself and start your voice.
Please call him on mobile, I think.
Yeah.
Sorry, sir.
Yeah.
No, sorry,
Hi, Dr. Goel.
Hello, am I audible?
Yes, sir. Your both audio and video.
Yes, very much so. We can see you and hear you now. Dr. Goel, can you go ahead with your first presentation, please?
technical team, can you help me, sir, for sharing his screen?
Sir, may I know the reason? Are you able to share your screen, sir? Or you need any help from our end? Goel, sir?
Hello,
Yes, sir.
is someone going to start the proceedings?
Sir, it's already started, sir. You
Already
can
So Dr.
started, sir.
Gold, we already
with
did the
your
introductions and
presentation, sir.
everything. So we're just waiting for you to get on.
I
Well,
think I am not audible.
no, you are.
Sir, you are very much
Hello?
audible, sir. Yeah, we can hear you,
Am I
sir.
audible?
Yes, sir.
You are audible, sir.
Dr. Goel,
Sir,
can you hear
sir,
us?
Sir, I'm talking from the backend
हाँ,
team.
नहीं आ रही है.
सर मैं बैकएंड टीम से बात कर रहा हूँ. सो हाउ कैन आई हेल्प यू सर? आई मीन आपकी आवाज आ रहा है.
Hello?
वीडियो भी आ रहा है.
Am I audible?
Yes, you are
Yes, you
very much
are.
audible.
Okay. So
Very much
someone has to start the proceedings, or I start my talk?
It's already done. Just go ahead to the talk, please. We're just waiting
Okay,
for the talk now.
Okay.
Yeah.
Okay. All right. Okay. Good evening, friends. So the talk that has been given to me is rationale for CTO PCI, that is evidence and indications. So this talk will be more of a didactic talk because I have to talk of evidence and indications. So I'll just tell you a few myths about CTOs. The CTOs are collateralized vessels, so maybe do not produce ischemia and thus do not need to be intervened. This is a myth, I think. Already being totally closed, there is no risk of acute event. Some people could say that. CTO intervention has no benefit towards mortality reduction. So no need to do a CTO intervention. And always need viability studies before intervening in CTO lesions. So the myths explained with real facts. No collaterals can truly compensate for natural flow, and they invariably leave the segment ischemic. So with CTO lying silent, you may have a stable clinical state, but fiddling with the lesion could damage segments proximally or collaterals in the distal segments and could still result in MI. Mortality reduction may not be the only indication to intervene, as symptom relief and improved quality of life is equally important, which is certainly achieved by a successful CTO intervention. And I'm going to show you some evidence and data for that. If a patient has obvious angina, then there is no need for reversible ischemia study. And if the subtended territory is normal or hypokinetic, but this is only needed if there is a viability, the area is abnormal. So two major potential benefits for CTO revascularization other than relief of symptoms, one should understand. One is that the availability of the expertise to open CTO vessel may avoid an impending bypass surgery procedure in any individual case, one. And second, an open CTO vessel could come out really handy in the unforeseen event of a remote territory MI in future, improving the patient's capacity to withstand the same, having a collateral providing option available. Otherwise, that would not be available if you leave it as CTO. So these are very two important indications. What benefit should I expect or want from a CTO intervention? I would think symptomatic benefit like angina relief, improved exercise capacity, improved quality of life is very important. Improvement in LV function, well, if it can happen, maybe that's also good. Decrease in long-term mortality, well, this is not certain. This is not certain out of a CTO. You have to accept that. And we have to still do it short of that. When do I ask for a CTO intervention? CTO vessel, if it is supplying at least 10% of the LV myocardium or more, CTO vessel must be responsible for the patient's symptoms, or there must be evidence of reversible ischemia in the territory subtended if the patient is asymptomatic. And the CTO lesion should have a realistic chance of success or at least a favorable risk-benefit ratio, then only you go ahead and do it. where operator expertise is going to play important. Now, going by the guidelines, this is 2011. The guidelines have not changed much. So it's class 2A, saying that PCI for chronic total occlusion in patients with appropriate clinical indications and suitable anatomy is reasonable when performed by operators with appropriate expertise. Then 2012 Euro CTO consensus statement says that CTO recanalization is indicated with symptoms and evidence of ischemia. In patients with prior Q wave MI, viability should be confirmed. 2014, the European Society Task Force again says something similar. So appropriateness of the percutaneous revascularization of coronary chronic total occlusions and overview in 2016. Well, this is showing the same summary that if is symptomatic, then you can go ahead and do it. If he is asymptomatic, then you need to look for reversible ischemia, and if the territory looks dead, then you need to look for viability. Now you want data. So what is the data? So where is the data? Now, an understanding of clinical outcomes of CTOs comes from post-primary PCI patients with residual non-IRA related CTOs and their outcomes. That is one group of patients. Second group of studies are those where a large outcome data is an extrapolation of outcomes of successful CTOs versus unsuccessful CTOs. These are all will be retrospective analysis. Well, prospective data from randomized controlled trials are limited. And we have two trials which were presented in 2017, which have made an important dent onto the CTO understanding, and I'll discuss that. One is the Dissection CTO and other is the Euro CTO. Dissection CTO, in fact, was published in 2019. So going by the post-MI trials, so this is one trial where Horizons AMI acute MI patients who had CTO were followed up for 3 years in the non-infarct related artery. And it was seen that multivessel disease patients with CTO in the non-IRA vessels over long term, over 3 years, did worse than those without CTO with multivessel and those with single vessel. So that is what it is. So in patients with STEMI undergoing primary PCI, CTO in a non-IRA was an independent predictor of increased late mortality after 3 years. Now, this is another study, the EXPLORE trial, again, post-MI, 304 patients with acute ST elevation MI undergoing primary PCI and have concurrent non-IRA CTO on 14 centers in Europe and Canada, randomized to CTO PCI or no PCI, 150 odd patients each, and looking for LV ejection fraction after 4 months. Well, there was no significant difference in LV ejection fraction. Well, there are a lot of limitations there as to what is the status of the infarct-related artery, how much improvement happened there, and things like that. So it was a negative study, but it has its own critiques. So there are other studies. This is a meta-analysis slide from meta-analysis, which shows that independently CTO interventions do improve some LVEF over follow-up. And that is what these studies have shown. Now, the second group of studies where you analyze successful CTO PCI versus unsuccessful CTO PCI. So this is the group. And here also there are some studies. The studies are not in large numbers, you know, the number of patients are always smaller. 125 patients completed the Seattle Angina Questionnaire at baseline and 1 month after CTO PCI with 55% procedural success, because CTO is one intervention where procedural success could vary, you know. So those who had a successful procedure probably did better, the symptomatic ones. So in symptomatic patients, it improves the angina status and quality of life. That's what was found. And some more studies in a meta-analysis form, and they show that there is a significant improvement in the symptom status and quality of life in successful CTO PCIs as against unsuccessful. Another study, long-term follow-up, elective chronic total occlusion angioplasty. This is a large number of patients there, 13,000 patients with 14,000 CTO procedures from the UK central database, central cardiac audit database, followed up at 2.5 years. And again, similar side of results that no CTO PCI success gives you worse outcomes than CTO PCI success. I'll skip over this similar results. Now I'll talk about the prospective two trials, the Dissection CTO and the Euro CTO. So the Dissection CTO, which was just published in 2019, this is the trial, and it had 834 patients, 398 randomized to optimal medical therapy and 417 to PCI group. But the issue was several of these patients jumped across onto the other side, and about 20% of the medical treatment group went on to PCI. And similarly, several of the PCI group, some of them did not have the procedure. So that crossover was there. But this trial was truly negative. It did not show any benefit in the primary endpoint, which is death, MI, stroke, and repeat revascularization. And it is quoted quite strongly that against CTO intervention. But you see, this has few major limitations, and one has to understand that. And the limitations are, majority had multi-vessel disease with non-CTO vessel PCI done prior to randomization to the CTO PCI. And the clinical status post non-CTO PCI is not clear. That group, that has not been randomized, that they will have similar outcomes. They will have similar EF, similar things. Now, the recruitment was rather slow with target enrollment not reached at all. And the study was terminated early and went on for at least 6 years. And there was a crossover of more than 20% both sides. So the study has its own limitations. The Euro CTO trial, which was again presented in the Euro PCR in 2017 by Dr. Werner. And this is what it showed, similar type of a trial, but this is only a clinical analysis. So one group into PCI and another group onto optimal medical therapy. But what they found was those on PCI, they improved in their symptom status much better, much more. As you see, those in class 1, 0, 1 and class 2 were much higher in the PCI group than in the optimal medical therapy group. So clinically, the Canadian class change was better. And similarly, the Seattle Angina Questionnaire also showed, in fact, here, the bigger the questionnaire, the better you are. So it shows bigger changes in the red bars, which are PCI bars, as against medical treatment bars, which are blue bars. Now, in CTO PCI, the other thing that creates issue is the completeness of revascularization. And there is a negative impact of incomplete revascularization, which was shown in the Syntax trial, and where it was surmised that within the PCI and CABG arms of all comers Syntax trial, angiographically determined incomplete revascularization has a detrimental effect on long-term clinical outcomes. This effect remained consistent in patients with and without CTOs. Now, lastly, I would say seeing is believing, in the sense I personally practice what I see, what I have understood myself, and try to publish, analyze it. And my data, this is long-term outcomes post-chronic total occlusion intervention, implications of completeness of revascularization. This was published in the Journal of Interventional Cardiology, where analysis of about 10 years of CTOs, 632 odd CTOs was done, follow-up available in 86% with 89% success, and complete revascularization obtained in 74%. And what we saw was that the total country survival was better with CTO success than failure. And when you have complete considering the completeness of revascularization, when you have complete revascularization, then angina is also better. And that is what we found. So these are the Kaplan-Meier curves, which show the difference in complete versus incomplete and CTO success versus failure. So to conclude, friends, what I wanted to say was, there seems enough rationale for CTO PCI in symptomatic patients or those with documented ischemia, provided the area subtended is more than 10% of the myocardium, and operator expertise may be crucial. Dissection CTO certainly is one stumbling block, but has several limitations. Itself in more studies to that effect. because it had low power for clinical events and high crossover rates. A good prospective long-term outcome trial, although still awaited, may be extremely difficult to execute because of the results of CTO. You put the patient on the CTO intervention group, but whether you succeed or not, that will make a difference. And symptomatic relief and improved quality of life post-successful CTO PCI is a certainty. You will certainly get that. Completeness of revascularization could be equally important. One should consider that. Thank you.
Thank you, Dr. Goel. That was a fantastic talk, a very difficult topic. So you kind of made the case for CTO PCI. We have a lot of panelists and expert, and chairpersons here. I'd now like to open it up. So Dr. Sikandar, Dr. Kashinath, do anyone of you kind of want to have a brief discussion? We would like to stick on time moving forward. Like I would request that the speakers just stick to 12 minutes and so that we have a meaningful discussion at the end. Dr. Sikandar?
So I think we take the questions together at the last because already we are running late. So
that's fine. That's perfect. Sounds great. Sounds great, guys. So then I would just urge all the speakers to wait till the very end, if that's all right. Thank you very, very much. So I'm just going to go ahead. I think I'm the next speaker, correct?
Yes, sir, you are the
Awesome. Great. So let me just go ahead, show all windows. Okay. Can I share my screen?
Yeah, I'm stopping share. Yeah.
All good. Can you see my screen?
Yeah, sir, we're able to
Awesome.
see your screen. Yep.
Super. Okay, good. Hold on just a minute. Okay. There we go. So I'm supposed to talk on retrograde CTO PCI, and I'm going to try and wrap it up in 12 minutes. So we're going to just touch upon what are the basics of retrograde CTO PCI. We're not going to extensively discuss on equipment given the times. I'll show you a couple of cases depending on how much time we have and some essential skill sets that people ought to have before they start embarking on CTO PCI. Now, if you think about it, there are multiple algorithms that have kind of talked about how do you approach CTO PCI. Long story short, I think there is a definite role for retrograde CTO PCI, especially when you have run out of antegrade options. And again, now I think it's well accepted both in the Asia Pacific region. Obviously, the Japanese are kind of the pioneers in it, as well as in the Western world, that retrograde CTO PCI is here to stay. So just to go over the basics. So fundamentally, if you think about it, you have to get access to the vessel, distal to the CTO, right? So whether this is a conduit through a septal collateral, epicardial collateral, or bypass graft, there are various kinds, obviously, you have to be able to get there. And then you have to cross the CTO segment itself, both antegrade and retrograde, and a variety of techniques here. So if you do a pure wire escalation, that's RWE, there are multiple ways by which you could achieve reverse cart. And of course, cart, which is where you take a balloon retrograde and then you kind of connect the dots from antegrade. So you can achieve it through one of these three strategies. And once you've connected across the CTO segment itself, you still need to externalize the wire, can make it into an antegrade system and then finish the procedure itself. The key thing is, even as you're setting it up, don't pan. Ensure that you always have a orthogonal views. Make sure it's bilateral angiograms, etc. You do need to know your equipment because otherwise you're going to be in trouble. You need to be very comfortable with microcatheters and wires, to say the least. And then remember, typically when you're starting off with septals are one of the easiest things to do. And if you are going to do this, I would highly urge that you would start with septals before you embark on epicardials. And if you are a surfer, then typically use a polymer jacketed wire. Like I said, you don't want to be in a situation where you go into the 135 course microcatheter and then you're ending up in trouble. There are a plethora of microcatheters out in the market. I'm just kind of listing a couple. So this is not an exhaustive discussion on hardware. So the next thing that I do want to embark on is to actually show you how it all kind of comes together in a case. So this is a RCA CTO that I did a few years ago. As you can see, it's a pretty long segment. RCA, there's some calcium there. And what we already know about this is it's a pretty long segment. The cap is pretty unambiguous. And I'm so sorry, 1 second. Okay, so the cap, let me just get back. Okay, the cap is pretty unambiguous. This case was attempted before, and there was a failure. There's a significant amount of calcium, and also the distal catheter bifurcation. For a second, my PC is not charging as we speak, so I'm just going to move a little bit. And so the plan here is that I decided that I was going to go with reverse card, and if that didn't work for whatever reason, is to perform a high-end ADR. So the first thing when you start retrograde is to really prepare the antegrade bed. So as you can see, 2 catheters, and then I didn't even try, given that I was going to do reverse card. I didn't even try to wire it. So this was just a knuckle that gets started. Despite having guide extension catheters and despite a lot of the other stuff, the guide was getting kicked out. So the next thing that you want to do is, I tried to get a microcatheter over this, etc. I couldn't do much there. So it was a shortened wire, and I started drilling it. And that's why because the wire is shortened, you can see that the radiopaque is a little bit shorter. Once this was done with the 1.5 burr, obviously this is into the subintimal space. Now you can see that even without a guide extension catheter, towards the end, you'll just see it here, that the microcatheter just sails right through because you're prepared to bed better. And now, got a knuckle down, I'm all set for reverse card. So antegrade bed preparation is done. Balloon, guide extension catheter, all set up now. Now I have to cross and get to the distal part. So crossing this collateral itself wasn't too much of a challenge. Just cross with the regular Sion. As you can see, there's a Corsair. And now the other thing to remember is that the distal cap was truly at a bifurcation. So typically when it's this case, you don't want to do ADR unless it's a bailout strategy because you want to preserve both branches. So got a retrograde knuckle going after I did an initial penetration. So now it's fairly straightforward. You got a retrograde knuckle and an antegrade knuckle. And just understand what these terms are for those that are new to this, is you essentially, inflate a balloon, and then you want to bring in a wire into the same space that the balloon has created. And most of what we do these days, especially with reverse card, is guide extension reverse card, especially when you're dealing with long segments. So what you do is have a guide extension catheter, have a balloon that's inflated, and once that's inflated, your retrograde wire can get into the same space. Here you can see that the balloon is already inflated, gone back, and then your retrograde wire just gets back in. And remember, there are multiple steps in retrograding. I'll be careful. Once the wire is out and externalized, you essentially put in a needle introducer, get the externalized wire into the needle introducer, connect it. Now the key thing is don't pull, push the wire here, and it'll just come out automatically. So the rest is just PCI. This is still optimized with imaging, and we just want to be sure that you preserve all the branches, etc. And that was the end result. And so, the total case took about 2.5 hours, and done in a live setting. I got about 2.5 minutes left, so I'm just going to show you a few key points. So a lot of stuff can be done. This was a case where the collateral itself was really wicked, and this is a more, I would say, a high-end retrograde collateral where it's epicardial. Typically, epicardials are much more challenging. We had to use a dual lumen catheter even to get into the collateral. And this is a circ CTO coming from the right, as you can see. And if you look at the distal part of this, the collateral comes right at the distal cap, which makes it even more challenging. So this, again, requires some of the newer wires, such as the SUO 03. These days, that's pretty much the default the wire for crossing epicardials. And what made this case a little bit more fun and challenging was this. So so actually this case ended up being had to use multiple strategies, including Carlino. I'm not showing this case because this should be a first one, but what I am saying is that you need to be comfortable with various techniques. As you can see, when you're doing techniques like this, it's important to protect the other vessel. And you have a wire down in the high OM itself. And then essentially what I ended up doing was use my retrograde wire as a marker to come antigrade. And this was done, and I'll just show you the final result in the interest of time. So this was post PCI, and there you go. But the key with CTO PCI is don't get dogmatic. This was a super difficult circ to essentially open up. So you had to use multiple techniques. I got about 55 seconds, so I'm not going to waste a lot of time in these things. But I think one of the most underappreciated techniques that's often missed is you got to know how to knuckle. Knuckles really do help sort ambiguity, as you can see in out here. There's no way you're going to be able to wire this true to, because you have no idea about the course unless you have a CT up front. So and snaring is something else that people do need to know, especially when you're dealing with osteal calcitic vessels. I mean, you have no option but to snare it, because getting any kind of antigrade gear in this particular case was next to impossible. So I'm just going to go to my conclusion slide. Hold on. Okay. So what I would like to emphasize on essentially is here. Okay, so again, this was another case where you used retrograde, antigrade, and actually was ADR because there was just this one rend of place which I just couldn't get across. So anyways, the point, let me just show you okay, always have a plan. Now, there are subtle differences between various parts of the world in terms of when you approach it, how you approach it, whether you knuckle, etc. But the key is to have a plan, some plan. And if you don't plan, it's almost a given, going back to what Dr. P.K. Goel said, is that is a high likelihood you're going to fail. And don't get dogmatic on how you're going to do this. Be ready to switch. Thank you. I believe the discussion is going to be at the very end, correct?
Yeah, I think you go ahead. Next, I think is Dr. Chopra. Is Dr. Chopra there?
Next is Dr. Arun Kumar Chopra, right?
Yes, sir, but
Is he on?
yeah, no, he haven't joined it. I had tried to. Yeah. We can
we get
Dr.
Dr. Sumitsuji Sensei to kind of give the next talk, and perhaps hopefully,
It's mine.
would that be all right?
All right. I'm okay. I'm waiting. Is it okay
Awesome,
to start?
brother. Let's go. Let's roll.
Okay. So can you see my slide?
Yep, sir.
Yes, we do, Sensei. Yep.
I was guided. Okay.
Yep.
So this is my CTO COI disclosures. And then I was guided CTO PCI wiring. Of course, in the antegrade situation, retrograde situation, and in the antegrade CTO entry, or I was guided rewiring in the CTO segment, or most of the time using the IVUS for the retrograde is reverse current. But before talking about this, we must know the histopathologic, the features of the coronary artery. This is very important, the key point, basic point. As you know, the intima plaque, media, and adventitia 3-layer is a coronary artery construction, but it is very interesting compared to the peripheral arteries, ATA, SFA. Coronary artery have more thinner the media and very thin external elastic lamina. The many times wire easy to go to the outer side of the vessel due to the curvature, due to the calcium and dense fibers. And then when the wire tip come to the outer side of the vessel, that means the media. This is the size of the 0.014 wire tip. So that is much bigger than the media and much bigger than the EL. EL is very thin. Even the 0.008, the wire, like this one, the size is enough big to puncture the media layer with very stiff tip. No doubt. Once wire come to the outer side, very easy to go through the media and the media adventitia border, like here. Why we don't have so many times the perforation? Because the adventitia is very expandable, like the rubber. So two layers, two materials, media and adventitia, easy to be dissected and make the space. This is a big advantage to avoid the wire perforation, but that is creating a subintimal big space. And why the space could be big? Because the adventitia could be expand. Even the 148 millimeter Hg, that is a normal systolic blood pressure, can make the 1.8 times the expansion of the adventitia. That means 3 millimeter vessel could be the 5.4. So what happened is, this is the initial situation, and they make the dissection here between the media and the adventitia, make the this space big with the blood pressure or rough wire manipulation. And then we can see here, this part. This is a big subintimal space. Finally, collapse the distal lumen and the failure of the antegrade. This is the almost all reason, mechanism of the antegrade wire failure. And then this is good situation for the retrograde. Unlike in the previous presentation shown. So how to use the IVUS? IVUS used for getting the histopathological information during the procedure. Number one, entry point. If the wire comes here, this is close to the EL. That means high risk of the subintimal tracking. If the wire position more than 0.3 millimeter far away from the EL, that is almost sure inside the plaque. Okay. So this case, meet like coronary total occlusion, and then the first wire go to close to the EL. We can do a little bit more because this is the Carina side. Carina side, the media could be thin. So maybe sometimes even the wire advanced very close to the EL, but could be inside the plaque. So we advance wire, but the wire not successful. So repuncture, different point, more center of the vessel. And the wire here. In the still image, that is here. This is 1 millimeter. So that is surely more than 0.3 millimeter inner side from the ear. That is almost sure that is inside the plaque. So we can do the part wire with this second wire and then success. IVUS and the histopathologic information connected during the procedure. In the total occlusion, this is a case until the failure and later with no channel. I tried and failed all of the channel and then tried to do the IVUS guided rewiring. Target here. plaque is target for the antegrade. For the retrograde, subintima, extra plaque is okay. Just inside the adventitia is okay, but the antegrade success need a wire tracking inside the plaque. So where is the plaque? We can see with IVUS. And then this is the proximal part, mid part, entry point of the wiring point, and this is distal. Distance from the IVUS catheter to the center of the plaque and the direction. This is almost the same with the RV branch direction in the distal. In the mid part, little bit counterclockwise. So put the data on the angiogram. Around the 2 millimeter, this is the RV branch. So RV branch is branching to coming to our side. So little bit counterclockwise means this side. And then 2 millimeter. Then this plaque, target plaque move to the clockwise rotation. That means like this. With understanding this information, we can control the wire to this target point. Then this conquest per 12 successfully come into the plaque, almost center of the plaque, and this is succeeded. Final point is a reverse retrograde, reverse cut situation. So this is the current, the updated classification of the retrograde CTO wiring, direct wire cross ante, direct wire cross retro, kissing wire cross antegrade, kissing wire cross retrograde, cut, reverse cut, extended reverse cut. And most of the case, we do the reverse cut. Reverse cut, how to cross a wire. Just a knuckling, big balloon, that's one option. But even doing the big balloon, sometimes we fail to wire cross. Key point is IVUS, because IVUS can tell us the wire position. Plaque and plaque, or subintima plaque, plaque and subintima, subintima. And this pattern is like this one, in the longitudinal position. Go to the proximal true lumen, antegrade wire tend to be inside the plaque. In the contrary, the go to the distal true lumen, retrograde wire tend to be remaining in the position inside the plaque. And then far away from the entry, risk of the subintimal tracking is getting high and high, antegrade and retrograde both. So that means in the proximal part of the CTO, many cases have the plaque and the subintima. If in this situation we can get with the IVUS, advance in the antegrade wire, and then change the situation sub and sub on the plaque and plaque. Sub and sub, balloon and the wire cross is easy. Plaque and plaque, of course we can do the puncture. Even this situation, just only the situation is available to cross a wire, okay, do the reverse cut using a big size balloon to make the intentional medial dissection. If antegrade wire subintimal retrograde wire in the plaque, advance the retrograde wire up more proximal, then change the situation. So after getting the IVUS information, we can do all the wire step very logically.
Schedule a meeting, join a meeting, what's the meeting?
Please mute it.
Guys, please
Okay,
mute.
thanks. Okay, thanks. So the getting the IVUS information and translate to the histopathologic, the information during the procedure is key to success. Okay, this is summary. IVUS can show us the histopathological information of the coronary arteries, and the histopathologic characteristics of the coronary artery greatly influence the CTO PCI wire procedure. And then knowing the histopathologic information, that is the leading the procedure, wire procedure to success. And I'm doing the e-learning. Which? E-learning. Uh-oh. Just a moment. It's not very important. Like this. I did a forum that is based using the Japanese and both Japanese and English. So please join and then check the many cases and share the information of the cases and the presentation. Thank you. This is my presentation. Over. Thank you for your attention.
Thank you, Dr. Sumitsuji. That was, as always, a masterful talk. Thank you very, very much again. Really appreciated it. Guys, can we now have Dr. Chopra? Is he on? Do we know if he's on?
No, sir, he is unable to join the meeting right now, so we can start with the next speaker.
All right.
We can,
Okay.
yeah.
So I guess then now one of the most important talks, I think, is about complications, and I would like to invite Dr. Sunandan Sikdar to give this talk.
Sorry, you're muted.
Sunandan, sir, please unmute yourself. Yeah, you are muted.
So yeah,
Thank
okay.
you.
So we start with the session of CTO complication. I am Dr. Sikdar from NH Jessel Road. So we can, why there is a higher complication in CTO? So obviously that we have a hard calcified lesion often. We have stiff wires. We use microcatheters, and often the catheters that we use have a strong backup. And patients may have multivessel disease, contrast use, and time is low. In the many different trials, one of them was a consistent CTO trial. The tamponade was around 1%, perforation around 5%, bleeding 2%, and vascular complication is around 6%. So among the complications, we can divide into two groups. One of the general complications that are related to the PCI itself, and the other complications which are specific to CTOs. So in general complication, arterial access complications have increased in CTO because often dual access is necessary. The contrast load is higher, and often there is requirement for contralateral injections. There are often vasovagal reactions. Rarely intracranial bleed can occur. Air embolism, because often there is the possibility of back bleed is less in case of CTO because we are often accessing vessels that are where the catheter is in a wedge position. Coming to the complications specific to CTO, we have Cath induced dissection. So often there is a diffuse disease in the proximal part, and when catheter with a strong backup is used, there may be an ostial dissection. If anyone wants to pursue the CTO in spite of that, he has to stent the ostial dissection and then go ahead with the CTO. Retrograde aortocoronary dissection can also occur, which may require surgical intervention because there may be aortic regurgitation or involvement of neck vessels also. This is also a very serious complication where hemodynamic collapse may occur if the left main is involved. So contrast is quite high in CTO, and roughly we may consider that 4 times the GFR is the limit that we can go. There is a formula for calculating contrast. That is the Sigarua formula, 5 into body weight divided by serum creatinine. Coming to the wire-induced complications, we all know that wire shape and wire shaping is important, and often we have go to the subintimal space, and as a result of that, we always want to go out from the subintimal space and back to the true lumen. But unfortunately, sometimes we may have, because of strong wires like Conquest Pro, or sometimes while we are using higher wires like Gaia Third, we may have a perforation, and we can have spiral dissection. So perforations are important because they are often the Achilles heel of the CTO. And one of the reasons for perforation is increased calcium and tortuosity. Often it is because of aggressive ballooning or sometimes stenting in a vessel which is small. So the risk factors are this, and the treatment for perforation is like other coronary arteries also, means not, other standard PCI, like most of the time, if it is in a small vessel, often balloon inflation for a longer time with the help. If it is in a vessel with more than 2.75 millimeter diameter, we may require a stent graft. And in a small vessel, we can even embolize. Sometimes protamine is required, but that has the problem of having a stent thrombosis also, or these thrombosis in other vessels. So in order to avoid this, we must have a feeling of how the guide wire is going. And in order to avoid this, we must look at the guide wire when we are withdrawing the guide wire. If there is resistance, if there is a feeling of being stuck, there it is possible that we are in the subintimal space and we may be in very near to perforation. And if there is perforation, movement may certainly increase if we are in the pericardial space. In case of guide wire induced dissection, we must avoid antegrade contrast and we must use imaging techniques to continue with the CTO. And sometimes if there is a dissection which is unavoidable and if their flow is compromised, or if it is in the LMCA, we may require to stent it. So stent loss is also a problem. It occurs particularly because of inadequate lesion preparation in calcified and tortuous vessels and forceful pull. It occurs because of undeployed stent or an unexpanded stent or stenting in an unintended location. So while we pull the stent may get deformed while it hits the guide catheter. Or sometimes the stent may be unstuck on the lesion and the balloon is withdrawn. So if we have such in this situation, what we can do is advance a deflated balloon beyond the stent, and after advancing it beyond the stent, we inflate and bring it back along with the entire system and withdraw the entire system. Sometimes we may dislodge the stent, and if it is on a wire, then we can also put a second wire and twist them together and bring out the entire system. Really, we can use a coronary snare. So there is a problem of broken balloons also, where we may require to do a balloon trapping. There may be a possibility of guide wire fracture. As we can see in the figures, the guide wire may be retained in the coronary artery. Sometimes we require to stent it. What is the management of guide wire fracture? If you have a fractured guide wire, we can use a second wire to twist that guide wire and bring out the entire thing. Or we can use an advanced balloon and trap the guide wire and bring out the entire system. One of the catastrophic things that we have is donor artery thrombosis in a retrograde procedure. And one of the key ways of prevention is to keep the ACT above 350 and measure ACT very regularly, always flush the guide and disengage the guide from time to time. And the treatment of this can be done by removal of the retrograde system, wiring and thrombosuction, rarely stenting. Transient myocardial ischemia may occur in prolonged retrograde approach if the collaterals are sheared out. There may be complications which is related to the hardware. Corsair can have complications predominantly used in retrograde approach. We may have the Corsair catheter collapsing if too much torque is given. It may also get stuck in a calcified CTO. Tornus can have its own complication. The proximal part of the tornus may break if there is too much torque. Also, in a false passage, if a tornus is used, perforation can occur. So this is another problem. If you are doing a retrograde CTO, there may be damage to the collateral channels. There may be wire perforation, microcatheter induced perforation, and balloon dilatation can also damage the vessels. The effect can be the septal hematoma. Sometimes it can occur if it occurs in the epicardial vessels, then we can have a tamponade. See what we do in epicardial channel perforation. One of the very important thing is not to lose your cool. You maintain a negative pressure through the microcatheter that we are in. Remember that we cannot be delivering coils or gel foams for Corsair, and you require to change it to a fine cross microcatheter. And after that, always look that antegrade flow channels, whether they are contributing to the bleeding. Thus, after stabilization, this patient can be, the procedure can be, if required, it can be aborted. So we had a patient who had a CTO, and ultimately we were able to wire it with a Guidewire. But once we started to balloon it, there was severe hypotension and almost leading to pre-arrest, and it was ultimately salvaged by CPR and after giving high dose of vasopressors. And ultimately, we stabilized the patient and continued the process. And so this was the result. But we didn't find any pericardial effusion, and the catheter was wedged from the initial time. So So we do not know exactly what was the reason for this hypotension. But one possible explanation, there may be some intramural hematoma, and this is also one reason why we can have hypotension in a CTO, and we do not find any pericardial effusion and echocardiogram. So coming to radiation, we always have to be careful about the operator, and we should reduce the table and the detector distance so that the radiation is less. We should use less amount of ileocranial views because that has the highest amount of radiation, or you can also use rat pad. We must remember that ionizing radiation is the only unequivocal risk factors for a meningeal neoplasm. Thank you.
Great talk, Dr. Sikandar. Thanks a lot. Hey guys, looks like we don't have the ADR talk. So just a question to the chairpersons and the panelists. Shall we just save more time for discussion, or I can?
Yeah, we can have.
Yeah, that'll be better. I do have a talk on ADR if you want, but doesn't matter. So why don't we just open it up for discussion then? Yeah, I think.
Sorry. I'm sorry.
Hello.
Yeah, hi.
Hello.
I have to leave, so I do want to the one comment before leaving. Is okay?
Absolutely.
Okay.
Sure.
So just one thing, the evidence part. So maybe you don't check it, but the JACC journal 2020, Japanese group showed CTO is risk factor of out-hospital cardiac arrest. That is very important. So out-hospital cardiac arrest, almost outside of our target. They did the mechanical CPR. So very special situation makes the CTO is risk factor of out-hospital cardiac arrest. So please remember it.
You should mute, please, just the person.
Dr. Ashok?
Yes. Hello.
Okay. Did you get my point? So CTO is the risk factor of out-hospital cardiac arrest. Very, very important. Thank you so much.
Hey, thanks so much for joining. Really appreciate your time.
Sorry for leaving.
Can I have one question? Can I have one question?
See you next time.
Hello. 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 Hello.
Dr. Ashok?
Yes, can I have one question?
Yeah, we can have questions now because we have time.
Please go ahead. Let's just open it up for questions and discussion.
Okay. Now, Dr. Kalyan Sundaram, now I'd like to ask you, this CTO procedure always by default it should be femoral or it should be radial also?
Dealer's choice. I mean, obviously, I think there's enough data today that femoral does have a higher complication rate, especially when we are considering left femoral axis. Again, depends on the CTO per se. For me, axis is axis. I mean, you got to be comfortable as an interventionalist, whether you want to go radial, femoral, whatever. Traditionally, we used to use 845 sheets bifemoral. These days, I tend to go more femoral radial. There are operators that do go by radial. I've done it occasionally. I'm not a big fan of that. With the slender sheets, yes, you can technically get 7 French, but I like to do right radial, right femoral, or bifemoral. Typically, that's my usual stuff. So it doesn't have to be, but I would say don't try and be cute. Don't say like, well, I can do them all with 6 French or 5 French. I mean, it's a CTO. So make it easy on yourself. I would love to hear what Dr. PK Goel has to say about this.
Yeah, thanks, Arun. I think it is a question of your convenience, what you are more comfortable with. Well, and the guiding size has to be 7 French minimum. I always do it with 7 French, but I do radial, 1 femoral, and I do not do biradial, although my routine cases are nearly 100% radial. Because left radial is very tedious, you know, the way it comes and all. So that's the reason controlling from the left radial is a little difficult. So we use 1 radial and 1 femoral, but it is always 7 French, not less than that. And I don't use 8 French. Majority of the work is possible on 7 French today.
Agreed.
Dr. Kulyana Sundaram.
Yeah.
Hello. How
Yeah,
often
go
do you
ahead.
use crossbows?
So two things. One, I mean, its use has gotten lower and lower. I mean, I would say in globally, we do use it still for ISR at times. Many times, I mean, if you want to give me a second, it's probably easier if I can share my screen for a second here.
In summary, these are excellent tools when we are going for devices like TAVI or endovascular procedures, larger range, more than 8 French, access. But for smaller access like 7 French or 6 French, the use of these devices should be left on physician's discretion. Thank you so much for the patient here.
Okay.
Actually, the use of crossbars was the catheter that carried the stingray, created space to carry the stingray balloon. But now you can, it is not really needed, as he said, because I do majority of ADRs with.
Yeah. First of all, congratulations, Dilip. You are day by day becoming versatile. I'm really proud of you.
Guys, are we hearing another room too? I'm like super.
Yeah, there's some confusion.
And really, you have given a very good lecture and a wonderful exposition of the subject, and you have also finished in time. So now, in the era of this.
Okay, thank you. I guess that was good. So, so if you do want to see it still, as Dr. Goyal just said, I mean, we are using it lesser and lesser. ISR, we still use it. Many times, the space that your microcatheter has achieved is enough to deliver your stingray balloon catheter.
Yeah, that's right.
And if you do want to see it, I'm happy to show a slide or two.
Yeah, please.
Okay, give me a second. Guys, can I have permission to share screen, please? All right, let me see. There we go.
Yeah, done, sir.
Thank you. Hold on 1 second. All right. So there we go. Can you see my slide?
Yeah.
All right. So typically, that's the crossbars that you see here. You know, from the 2E, it's got to be about 2 to 3 finger breadths. That's kind of how you want to do it. And then you cinch it. And then what you do is spin really fast. All right. So it's just it's essentially a blunt knuckle. That's all it does. And once it's there, and don't use it unless you have a tapered cap. You can use it as a finisher, but if you have a blunt cap, don't start with the crossbars. And you really want it to go to positions 4 or 5. That's the key thing. And once it's there, you want to exchange it for a stingray balloon catheter or a dual lumen catheter. Like once we get recrossed, I think that's going to be kind of a game changer. But essentially, the point is to get to your landing zone, which is defined as 4 or 5. If you are true to true, that's 5. Then you're done. If you're in 4, then you use a dedicated re-entry device to get there.
Dr. Goyal, sir, I'd like one question. Is there any cutoff ejection fraction you use when you think for revascularization of a CTO, because you require a lot of contrast? Suppose a patient has a CTO with an ejection fraction of 35% or 30%. What do you think? We go for CTO opening or you keep on maintaining it?
You see, this is a very broad statement that you have said. This will actually entail a risk to the total procedure. For any procedure, if I feel that the ejection fraction is very low, then I may want to do it with support, if at all. But otherwise, what specifically you're looking for is viability in that area which is dead, which is so-called having the wall motion abnormality. And if that area has viability being subtended by the CTO vessel, I will go ahead and do it. If that area has no viability, then I will not do it. But the total ejection fraction is a total risk to the patient as at large. And for that, you may need support if it is viable and you still want to do it.
Yeah, just to add to that, I mean, especially if you're going to go retrograde, you definitely want to consider support in a low EF patient. So, I mean, I completely agree with what Dr. PKG just said. So let me ask you about the complications, Dr. Sikandar. Like, so what is your number one and two rules that you do to avoid complications? Because I mean, I think there's one thing that we all know that we got to be careful about when you're dealing with CTO PCI, and clearly from registry data, we know that the complication rate is higher than routine PCI. So besides making sure the indications are good, so what are some checks and balances that you do to avoid complications?
So for one thing is that we instead of going for a guide which has less support, we have initially take a guide with good support, but we take a wire which will be more forgiving in the initial part. Then I go for the microcatheters, but we always have to keep in mind that we do not push the wire too hard. And definitely we always keep in mind that we should not use too much contrast, that I would like that it should not be more than say 250 ml. And sometimes if it is possible, we avoid giving antigrade injection so that the dissection flap does not progress too much.
If Dr. Arun,
Yeah.
if I could just make a line comment here. Whenever there is a complication, I think in principle, whatever complication it is, you should look into the cause of it, try to analyze why it has happened or what has happened, and try resolving it on the table as fast as possible. And whenever there is a bleed related complication like a perforation, or you have to somehow control it, you can balloon tamponade it and sit there, but never reverse the heparin till your hardware has come out of the body. Otherwise, with your hardware in and in the hurry you want to reverse heparin, some people have done that, and then you start having thrombosis of your hardware inside. So that is a very important thing I just wanted.
That's an excellent point. And hey, just to tag along, I mean, the one thing that I would say, Dr. Sikdar, just in terms of your prior talk, like I would not wait to 7 or 8 gray before you stop. I mean, I think we should all get comfortable with 7.5 frames, and I think I agree with a lot of the other things that you said in terms of reducing radiation. But you really want to seriously consider stopping the CTO PCI if you're not close to being done by 5 gray. You really should quit. And it's always easy to have another attempt than leave the victim of the skin burn. And I think, I mean, you know, I would say my own journey in CTO PCI, the biggest lesson in CTO PCI is knowing when to stop. After you made sure the indication is solid, right? I mean, you know, we talked about risk benefit assessment. It's not absolutely set in stone, because the risk benefit ratio, as you're doing this, it's like a real game and odds that's going on. So anytime the potential benefit outweighs the potential risk outweighs the potential benefit, we should consider stopping it. And so it's not something that's set in stone, because the odds might change during the course of the procedure. And I think that's particularly important for the more junior guys that are getting started. And I would say one of the other important things is have a discussion up front with one of your seniors. If you have the luxury of being able to get a proctor, great. But if you're, I mean, you almost never in today's day and age attempt a retrograde, you know, just by yourself, if you've never done one before. So I think the single biggest lesson is know when to stop, is what I tell people, especially when you're starting off.
About heparin, how much heparin do you think we should be using? What the beginners, how much heparin they should use when they're starting this?
So the rule of thumb is, you know, I would say antigrade, you want to, so these are the following things: ACT very meticulously, Q 30 minutes. Every 30 minutes, someone should be checking that. That's got to be an autopilot. Number 2, your target, if you're going to go antigrade, is around 300 plus. And if you're going retrograde, I would say 350 plus. So, I mean, I've worked in some centers, unfortunately, where they don't have ACT machines. And I just discovered that when I'm like, you know, halfway doing the procedure. So I'm very, very worried, especially if I have retrograde gear, because as, you know, Dr. Sananda just showed, like, you know, donor vessel thrombosis is not forgiving. So you have to be very meticulous in checking ACT, especially if you're going retrograde.
Dr. Kalyana Sundaram, what is your wire escalation strategy? It is as usual, starting from the usual protocol, and do you have any special strategy?
I actually just put it up in the chat box because I think Dr. Sikandar had asked that. So, I mean, typically if I have a microchannel that I think I'm just going to be able to wire, it's either a fighter or an XT series. I mean, XTR, XTA, the tip penetration is a little bit different. It's 0.6 versus 1. XTA is 1 and the other one is 0.6. So pick and choose. So if you're thinking about a microchannel, that's what I would start off with. I tend to start many times with an intermediate polymer jacketed wire, such as the Pilot 200. If I do want penetration, if I know I'm penetrating, then I take Confianza Pro 12, or I mean Conquest Pro 12 as we call it here, or Hornet 14. Now, if I want something with directionality and I'm just trying to get some penetration, but I also want to be able to direct it, I would choose Gaia. I mean, I don't use a lot of Gaia first. I tend to go Gaia second or third, most likely.
Dr. Goel, in your series, what percentage of the patients you require the retrograde approach?
I think it was about 11% or so.
Okay.
So retrograde are not too many, but yeah, it was about 11%.
Okay. Thank you.
So, Dr. Hazra, I mean, if I may, I mean, I think, one of the big things in India, if you look at it as a whole, right, we have some of the world's largest cardiac patients. I mean, unfortunately, right, we have, I mean, I personally think the number of retrogrades we do is far and few between. I mean, we should be doing more for one simple reason is that even if you're the world's best antegrade wire escalation guy, you're still going to have failures. I mean, Dr. P.K. Goel has a lot of patient database. I mean, he gets a lot of patients. If you're in a referral center and you have failures that are routinely coming, your percentage is going to be higher. But I think, the onus is on us to train more younger colleagues to do retrogrades, because sometimes persisting with antegrade is just doesn't work.
Yeah,
and you have to know when to switch.
Actually, what happens is, like my experience, I do cases right from scratch, in the sense they are not all CTO, because they, truly speaking, the colleagues inter-physician referral for CTO cases is very less. No interventionist would, if he does not able to do a CTO, would refer it to you to do a CTO. By and large, this is how the Indian setup is. But of late, we have started doing a lot of cases where the patient has a CTO and he, as a second opinion, he comes to you and then you say you will do it. But inter-physician referral, because I don't think is there between, because there is no identification of a CTO operator and a non-CTO operator. Everyone is an interventional cardiologist. I hope you understand what I say. Maybe you are getting some referrals like that. I don't know. We don't get that. At least in North India.
I'm pleasantly surprised. I mean, in Chennai, my practice is almost exclusively referral, because I don't have a patient base. So, and it's actually easier that way, because when a cardiologist sends you the patient, you end up, it's easier. So
because referrals are all types, you see. A person who has failed a CTO will some may send, I do get, but several of them, the patients come on their own rather than.
Got it. I hear you. So in Eastern India,
there are more sessions. Down the line.
No, perfect. I mean, guys, if you're ready to quit, I mean, unless there are any outstanding questions, I think we can move on. I mean, obviously, we are all available for, to be reached out. And actually, I think we're finishing 5 minutes ahead of time. So that's perfect.
Yeah, we are very now maintaining time.
So thank you so much.
We are on time. We are not.
Yep, we are good.
Thank you.
Okay. Right.
Thank you, guys. Bye-bye. Stay safe. Bye.